Hello there, my name is Valentine Beru. I am currently an FY1 NHS Land lecturer, and I'll be presenting on behalf of my colleagues on a study based in NHS Tayside titled Is Skin Thickening and Enhancement on Breast MRI Associated with Metastasis-Free Survival? First, a bit of background. With an increase in the use of neoadjuvant chemotherapy, there has been an increased interest in the use of preoperative predictors of survival. There have been multiple studies that have explored the prognostic power of various imaging characteristics, such as rim enhancement and perilesional edema on MRI, presence of abnormal nodes and skin thickening in ultrasound, and speculation of mammograms, which notably has been shown to have good prognostic power. We set out to identify associations between MRI-detected skin thickening, skin enhancement, and metastasis-free survival, given recent reports of skin thickening in ultrasound being a poor prognostic factor. So how did we go about doing this? Using a prospectively collected database, patients presenting between April 2012 and February 2015 with pre-treatment MRIs were selected. Women with metastatic disease at presentation were excluded. Patients in this study had given the consent for their data to be used for future research and for their outcomes to be followed up. The MRIs were assessed retrospectively using the BIRAD system by an experienced radiologist blinded to outcome. A range of variables was assessed as shown in the third bullet point, and data on patient survival and cause of death were extracted from local and national records. Statistical analysis was performed as set out in the last bullet point. What were our results? There were 212 patients in our study, with 214 lesions available for analysis. Patient age in our cohort ranged from 27 to 81, with a mean age of 56. 70% of patients had symptomatic lesions, and 30% were screen detected. 38% of patients received neoadjuvant chemotherapy. Over a mean follow-up period of 5.6 years, 10% of patients in our study developed distant metastasis. There were 18 deaths in the cohort, majority of which were breast cancer deaths. The graph on the left is the receiver operating characteristic ROC curve for index lesion size and shows that patients with large index lesion size at diagnosis are more likely to develop metastasis, and as can be deduced, larger sum of all masses as well as total lesion size, including non-mass enhancement, was also associated with a higher probability of distant metastasis. By looking at the area under the curve, or AUC, you can see the strongest association with poor metastasis-free survival in this study was found with the diameter of the index lesion, which is in keeping with the T and M staging system for breast cancer, where only the size of the index lesion is considered. Patients who had abnormal axillary nodes on MRI had poorer metastasis-free survival than those with normal nodes, with a hazard ratio of 3.36. It should be noted that ultrasound remains the first-line imaging for lymph nodes, although MRI can add valuable information, such as detecting perinodal edema on T2-weighted sequences. The finding that abnormal axillary nodes on MRI have a poor prognostic impact may be because MRI can identify women with a high nodal burden, but cannot diagnose many women with a low nodal burden due to its lower sensitivity. Skin thickening was described as present when non-areolar skin was greater than or equal to 2.5 mm in thickness. Patients who had skin thickening on their baseline MRI had a poorer metastasis-free survival than those without skin thickening, with a hazard ratio of 3.55. The poorer outcome associated with skin thickening on imaging is likely to be related to the presence of a florid, vascular, and lymphatic plexus beneath the skin, with skin thickening being a consequence of lymphovascular invasion and obstructive edema of the skin. Lymphovascular invasion is strongly associated with lymph node involvement and breast cancer-specific survival. Patients with skin enhancement also had a poorer metastasis-free survival than those without skin enhancement, with a hazard ratio of 5.44. Skin enhancement is a known feature of inflammatory cancer, but in our study, we have found it to occur in many tumors which are not clinically inflammatory. The results of this study suggest that skin enhancement in women without clinically inflammatory breast cancer may be a useful prognostic feature which can aid decisions regarding appropriateness of neoadjuvant chemotherapy. While most patients with skin thickening in our study had skin enhancement, a few did not. This suggests that non-enhancing skin thickening may be due to lymphatic obstruction from heavy axillary node involvement. This is an early post-contrast T1 weighted image showing marked skin thickening and enhancement in the left breast, shown by the red arrow. This slide lists the limitations in our study. Results were from a single center, and as the follow-up period was short, some women may develop metastasis in the future. Originally, we had aimed to look at breast cancer-specific survival, but the number of deaths were too small for meaningful analysis. Although metastatic breast cancer is incurable and is closely related to breast cancer survival, metastasis-free survival does not take into account the varied survival times seen in women with metastatic breast cancer. Participants were selected to have breast MRI as part of their routine care, which means that the findings cannot be applied to other breast cancer groups without confirmation from future studies. We can conclude that skin thickening and enhancement on MRI are associated with development of metastatic disease. The strength of what we have found is that skin thickening and enhancement appear to be significant features that should be explored further to see if they add value to predictive markers when it comes to deciding who gets neoadjuvant chemotherapy. Another use for this information would be when counseling patients regarding their prognosis. Here's a list of the references I've used in my presentation. Thank you very much for listening.